So guys, in this part, let's talk about the shoulder joint. In the shoulder joint, we need to first understand the articulation. We'll talk about the lining of the synovial and capsule attachment, the capsular thickening, that is a ligament. We'll also talk about the axis support. We'll also understand the relations of the shoulder joint, followed by its nerve supply, and finally about the muscles and the movements taking place at the shoulder. So without the further ado, let's start with the joint. Now, when we talk about the shoulder joint, the type of shoulder joint, it comes under the ball and socket joint. It's a ball and socket joint which comes under the synovial variety. There are only 4 examples of ball and socket joints, and one of them is a shoulder joint. We have a shoulder joint, we got a hip joint, we got incudostapedial, and then we have talocalcaneonavicular in the foot. So we got these 4 main examples of the ball and socket joint, and one is the shoulder. Let's start with the articulation first. Articulation, the bones which are participating in the joint. Now, obviously, one is the pear-shaped glenoid cavity. The pear-shaped glenoid cavity, it articulates with the head of the humerus. It articulates with the head of the humerus. So that's the 2 articular surface here. And when you look at the glenoid cavity is quite shallow. Now, that is the issue with the glenoid cavity. Unlike the acetabulum in the hip bone, the glenoid cavity is quite shallow. And if the glenoid cavity is quite shallow, that means the joint will become very unstable. Now, this is the thing. If you have a joint having a very strong stability, obviously the mobility will be compromised. And if they have a very strong mobility, their stability is compromised. So it is always inversely proportional to each other. Shoulder joint is such a freely movable joint. We can do the flexion and extension and abduction and circumduction all very freely because we have a shallow glenoid cavity, and the strength of the joint or the stability of the joint is compromised because of the shallow cavity. But to deepen this cavity a bit more than what it usually is, we have a fibrocartilage which is present on the margin of the glenoid cavity, and that is called as glenoidal labrum. So let's say if this here is the glenoid cavity here. Let's say it's a glenoid cavity. I'm writing GC. This glenoid cavity, on the margin of the glenoid cavity, we have a fibrocartilage which is deepening the socket, and that fibrocartilage is called as the glenoidal labrum. So that is the fibrocartilage which is deepening the glenoid cavity, and this is called as the glenoidal labrum. The word labrum came from the lip, that is, it's like a lip around the glenoid cavity, so we call it glenoidal labrum. So this glenoidal labrum is the one which helps in the deepening of the socket for this shoulder joint. It helps in the deepening of the glenoid cavity. Talking about the capsule of the shoulder joint, well, the shoulder joint capsule is attached, and let me show you diagrammatically. Well, if this here is the lateral border of the scapula with glenoid cavity, and here is the head of the humerus. So what you see, that capsule is attached. First of all, guys, if let's say if this here is the fibrocartilage, once again the glenoidal labrum attached to the margin of the glenoid cavity, the capsular attachment is exactly to the margin of the glenoid cavity. Look at this green color, I'm showing it for the capsule. It is at the margin of the glenoid cavity, and laterally is on the anatomical neck of the humerus. Laterally, it is on the anatomical neck of the humerus. So one attachment for the capsule, see, it's at the margin of glenoid cavity. I'm writing GC, margin of the glenoid cavity. Obviously, the labrum stays inside. It's intra-articular. And laterally, as you can appreciate, it is attached to the anatomical neck. To the anatomical neck of humerus. The surgical neck is having the nerve and the axillary nerve and the posterior circumflex humeral artery winding around it. It's the anatomical neck I'm talking about, to which we have attachment of this capsule here. If you remember the supra and the infraglenoid tubercle, supraglenoid tubercle is the origin for the long head of biceps brachii, which tells me when the long head of biceps brachii originates from here, it actually has to come out through the capsule. That is the long head. Obviously, it will come down like this and into the bicipital groove. So guys, if this here, let me just try to draw it further. So if this represents the long head of biceps brachii, so it tells me that long head of biceps brachii is intracapsular. It's inside the capsule. So the tendon of long head of biceps brachii is intracapsular. It originates from the supraglenoid tubercle, and that supraglenoid tubercle is obviously covered by the capsule. So obviously it is inside the capsule. It is okay. The thing with the capsule is not very strong for the shoulder joint. You cannot have a very strong capsule because you need to allow a lot of movement at the shoulder, and capsule, especially at the posterior side, is quite compromised. So what you see, how this capsule is supported, the weak capsule of the shoulder joint is supported, one, by some ligaments, we will discuss that, and also by the musculotendinous cuff, also called as a rotator cuff, present around it. So we'll discuss this with the diagram later on, but you can note it down that the capsule is reinforced by, or it is supported by the rotator cuff. It is supported by the rotator cuff muscles. And as you know that what are the rotator cuff muscles? We have subscapularis, we got supraspinatus, we got infraspinatus, we got teres minor. So the four muscles which are forming the rotator cuff, they're all supporting the capsule also. After capsule, coming to an important thing, that is the synovial lining. What about the synovial lining of the shoulder joint? The synovial lining of the shoulder joint, obviously, like synovial lining anywhere in any joint, if you talk about, it is obviously covering the inner side of the capsule, but not the articular surfaces. Articular surfaces are covered with hyaline cartilage. So obviously, you do not have a synovial lining on that. And whenever you see any synovial lining of the joint is coming out of the capsule, they usually form a bursa. Like we have so many bursas around the knee joint and hip joint, and similarly around the shoulder joint also. So they form a synovial sheath or the synovial bursa outside the capsule. Let me just again try to draw this, but first the point is that we said lining. This synovial lining, it lines the inner side of the capsule except on the articular structure, except on the articular surfaces, which is true for any joint to talk about. It lines inner aspect of capsule, except articular surfaces, And what are the articular surfaces we said? It's the glenoid cavity and the head of the humerus. That is the one which will not be covered. They are covered with the hyaline cartilage. So obviously they are not covered with the synovial lining. Now, this synovial lining, it extends. This synovial lining, it extends as a tubular sheath. It extends as a tubular sheath along long head of biceps brachii. We just saw that long head of biceps brachii was coming from inside the capsule. So when this long head of biceps brachii, it comes out of the capsule, we have a synovial lining also continuing around it. Goes into the bicipital groove along with this. So one extension of synovial lining is seen along with the long head of biceps brachii, and also deep to subscapularis muscle. Also deep to the subscapularis muscle, you will see another extension of the synovial lining which is extending deep to the subscapularis muscle, and that is what you call as a subscapular bursa. That is the subscapular bursa. As we said, what are bursas? Bursas are the extension of, bursa are nothing but the extension of the synovial lining only. So when you see this synovial lining of the shoulder joint, it comes out. I'll show you where exactly it comes out from. There is an aperture for that in the capsule. It comes out, and it comes out in front. What is the muscle which is covering the shoulder joint from the front is subscapularis. So basically, it is, this bursa is present deep to the subscapularis, and we call it the subscapular bursa. So the two major extension of the synovial lining is one is a tubular sheath along the long head of biceps brachii, and one as a subscapular bursa. Now let me just kind of draw it for you. Once again, if this here is the glenoid cavity, this is the now here's the greater tubercle, of course, and this is the lesser tubercle. The one in front, that is a lesser tubercle, right? That's a greater and the lesser tubercle you're looking at. Now, guys, talking about the synovial lining, as we said, this synovial lining is within the capsule. So we got it within the capsule here. And one, I said, it's an extension in front that is deep to the subscapularis muscle like this. You have the synovial lining extending a little below. It is like, because of the capsule also in this part is slightly slacked, it allows the abduction movement. So you have a synovial lining going a bit more downward if you compare it with the upper part, which is like more or less directly running from the scapula to the humerus. So we have a little more extension of the sleeve-like extension of the synovial lining in the lower part of the capsule. And then running within the capsule along this anatomical neck, you will see the extension of the synovial lining in the bicipital groove. Obviously, along what tendon? Along the tendon of long head of biceps brachii. Let me highlight that. That is one extension of the synovial lining, and that is the another lining extension of the synovial lining. This whole thing is the blue color here is representing the synovial line. The two extension we talked about, one is this, that is a subscapular bursa. This one is a subscapular bursa, which is more anteriorly, and the one which is going along with this long head of biceps brachii. This here is a long head of the biceps brachii, and that's the tubular sheath you can see, which is present around the long head between the greater and the lesser tubercle in the bicipital groove. So this is a little bit about that, how exactly the synovial lining is extending within the shoulder joint and what are the two major extensions, one with the long head and one deep to the subscapularis muscle. Coming to the support, we said capsule of the shoulder joint is not very strong, so we need some additional support, some external support from there. So the thickening of the capsule basically forms some true ligaments for the shoulder joint, and these true ligaments are called as the glenohumeral ligament. So talking about the ligaments of the shoulder joint, we can divide them in three parts. Well, the first one is the glenohumeral ligament. It's the glenohumeral ligament. Now, glenohumeral ligament, guys, is having three fibers. We have an upper, middle, and lower fiber. We got an upper fiber. I'm going to show it in diagram also. Just write it with me. Middle fiber, upper fiber is there. We got a middle fiber, and then we obviously got the lower fiber as well. Upper, middle, and lower fiber. Then the next ligament is called as a transverse humeral ligament. There's a ligament called as a transverse humeral ligament. This transverse, the name itself suggests that transverse humeral ligament is stretching between the greater tubercle and lesser tubercle. So it's a ligament on the humerus only. But still we consider it as a ligament of the shoulder joint complex, and we'll see it how. So transverse humeral ligament, as I said, it stretches between the greater tubercle and lesser tubercle. It stretches between the greater tubercle and the lesser tubercle of the humerus, that is transverse humeral ligament. And finally, we have a ligament called as the coracohumeral. The coracohumeral ligament, and this ligament, it extends. This ligament extends from the root of coracoid process. It extends from the root of coracoid process to the greater tubercle. Again, as I said, I'm going to show it to you in the diagram also. It extends from the root of the coracoid process to the greater tubercle. That's why the name is a coracohumeral ligament. So three ligaments in total, I would say. The one is a glenohumeral, we have a transverse humeral, and coracohumeral ligament. Now, the thing about glenohumeral ligament is, if you're dissecting the shoulder joint region and you approach it from the front, then once you remove the muscles and blood vessels and nerves and everything, then obviously you'll be able to appreciate, after removing the muscles also, you will appreciate the capsule of the shoulder joint, and you will not be able to appreciate any ligament there. It will look like a just normal capsule only. But once you cut the capsule and you see the capsule from the inside, then you will be able to see those fibers. The three bands I'm talking about, upper, middle, and lower band, or upper, middle, and lower fibers, those three bands of the glenohumeral ligament are appreciated from the inside and not from the outer aspect here. So not from the outer aspect. Let me just try to represent them diagrammatically. Once again, sticking to the same diagram here. This here is the glenoid cavity. And this time let's draw the coracoid process also. Okay. Well, so we said three bands of glenohumeral ligament, the upper band, middle band, lower band, they're all coming from the same line of attachment of the capsule itself. So this here is the, let us say this is the upper band here. Then we got this middle band. And then we have the lower band. So obviously all these three are the one which are the glenohumeral ligament. They are all together called as the glenohumeral ligament. And as you can see, the upper band, middle band, lower band, the three band, which I said can be appreciated from the more from the inside. Between the upper and the middle band, it's between the upper and the middle band from where the subscapular bursa will emerge out. Remember we talked about the subscapular bursa, which is an extension of synovial lining. So where exactly the subscapular bursa is coming out from? It is coming out between the upper and the middle band. This is an extension of the subscapular bursa through the capsule and the ligament, and that is between the upper band and the middle band. Remember that it's between the upper band and the middle band. Another ligament we said is a coracohumeral ligament, which comes from the base of the coracoid process to greater tubercle. Again, it's easy to draw. If this is the base of coracoid process, and here we have the greater tubercle, this ligament is called as the coracohumeral ligament. That's a coracohumeral ligament. So we have one glenohumeral, we got this coracohumeral ligament. Third ligament we said it's a transverse humeral ligament. Now what is this transverse humeral ligament and where it is present, guys? If this is a greater trochanter, a greater tuberosity or tubercle and lesser tubercle, so a ligament stretching between the greater and the lesser tubercle this way is what you call as the transverse humeral ligament. And what is the advantage of having this ligament? It actually keeps the check on the long head of biceps brachii and its synovial sheath. It's a long head of biceps brachii. I'm using this yellow highlighter again, which is a synovial sheath present around it. And that, let me just write that, that's the long head of biceps. And this long head of biceps is kept in check by the ligament that is transverse humeral ligament. So it's the transverse humeral ligament which keeps the long head of biceps brachii within the bicipital groove. If for a reason, let's say this ligament is injured, the long head of the biceps can come out of the bicipital groove, and that will disturb the stability of the shoulder joint from the lateral side. Long head of the biceps, because it is running toward the lateral side and coming out of the bicipital groove, so it is one of the factor which is providing the stability to the shoulder joint on the lateral aspect. So injury to transverse humeral ligament will cause the nipping out of the tendon of the long head of biceps, and that in turn can cause the instability of the shoulder joint on the lateral aspect. So these are the three ligaments of the shoulder joint you should know about. The glenohumeral ligament, which is having an upper, middle and lower band. Between the upper and middle band, we have subscapular bursa coming out from the aperture in the capsule. There's a transverse humeral ligament which holds the long head of biceps brachii, and there is a coracohumeral ligament extending from the base of the coracoid process to the greater tubercle, providing the support to the shoulder joint in the superior aspect. Apart from these structures, what other additional things provide the support to the shoulder joint? The two main things which are providing the support to shoulder joint is, we said, is a rotator cuff, and there is an arch which is present upon called as a coracoacromion arch, which I'm going to draw it with you also, and we'll show you in one atlas section as well. So additional support. So what is the additional support to the shoulder joint? Well, we said one is the ligament stretching between the coracoid process and acromion process, and that is called as a coracoacromion arch. That's coracoacromial arch, and this coracoacromial arch is also called as a secondary socket for shoulder joint. Secondary socket for the shoulder joint. I mean, it is present above the shoulder joint. Shoulder joint, rarely you will see that shoulder joint dislocates in the superior direction, because even if the rotator cuff is not able to hold the head of the humerus, above we have this ligament called as coracoacromial ligament, which forms an arch called as coracoacromial arch, made up of bones and ligaments. So this entire arch is acting as a secondary socket for the shoulder joint. The head of the humerus is using it as a secondary socket. And the second support of the shoulder joint, of this capsule of the shoulder joint, will be the musculotendinous cuff. Musculotendinous cuff, also called as the rotator cuff. Musculotendinous cuff or the rotator cuff, which again I'm going to show in the diagram itself. So let us draw a diagram in which we not only understand the glenoid cavity, we can see the tendon of long head, we can see how rotator cuff muscle are surrounding it. We'll also see even further outside that how deltoid is forming the relation and this coracoacromial arch is supporting it from the superior aspect. So basically, let's talk about the relations of the shoulder joint in the sagittal section. So we are looking at the relations of the shoulder joint, and guys, we are considering a sagittal section. So when you take a sagittal section, obviously the view is considered from the side. Now this here is the glenoid cavity. Once again, I'm drawing this glenoid cavity here. It's a sagittal section view exactly at the level of glenoid cavity, and imagine the head of the humerus is removed from here. So the humerus is removed, all I can see is glenoid cavity from the side. There's a capsule of the shoulder joint which is covering it all around, and we said it is slightly slacked in the lower part. That's the capsule of the shoulder joint, and this capsule is supported by the cuff called as a musculotendinous cuff. Now look at this, made up of tendons only and present all around, posteriorly, superiorly and anteriorly, but not inferiorly. That is musculotendinous cuff. And how many muscles form it? There are 4 muscles forming it. If you look at the anterior side first, the big muscle present on the anterior side here is subscapularis. Then we have muscle above, that is supraspinatus. Posteriorly we have infraspinatus, and then we have a teres minor muscle. So these are the 4 muscles which are constituting the rotator cuff. So we got if this is the anterior side, that has to be the subscapularis. This one here is the supraspinatus. I'm keeping these labeling slightly away because we still have to draw a few things around it. Supraspinatus. Then posteriorly I could see this is infraspinatus and teres minor. And teres minor, the 4 muscles forming the rotator cuff and supporting the shoulder joint from 3 sides, anteriorly, posteriorly, superiorly, but not inferiorly. Beyond that, what other additional support you will see? Well, above we have, let's say this is the acromion process here. That's a section going through the acromion process, and more in front here we have a coracoid process. Let's say this is a coracoid process. And stretching between the acromion and the coracoid process was the ligament called as a coracoacromion ligament, forming the arch called as a coracoacromion arch. Ligament is coracoacromion ligament. This entire arch is called as a coracoacromion arch. So this here is coracoacromial ligament extending from that acromion process. That's section through the acromion process, and that's rounded section is through the coracoid process. Obviously that is present. Acromion process is posterior, coracoid process is more anterior. And then what else you will see? You will also see the fibers of deltoid. You will see posterior fiber of deltoid here forming the posterior relation of the shoulder joint, and anterior fiber of deltoid are forming the anterior relation of the shoulder joint. So that's an additional, that's an add up here, that we have anterior and posterior support, which is by the deltoid fiber, the anterior fiber of deltoid and the posterior fiber of deltoid. This here is the anterior fibers of deltoid. Whereas these are the posterior fiber of deltoid. See what else, guys? We also said that supraglenoid tubercle, if this is a glenoid cavity, there should be a supraglenoid tubercle, is giving origin to the long head of biceps, which is intracapsular. Now, this green line here is representing the capsule. Let me just write that also. This green line here is representing the capsule of the shoulder joint. If this is a capsule, so the intracapsular tendon is the long head of biceps, which is present like this to the supraglenoid tubercle. So this here is the long head of biceps, long head of biceps brachii. Whereas infraglenoid tubercle, but outside the capsule, infraglenoid tubercle, which is outside the capsule, is giving origin to the long head of triceps. So in the inferior relation of the shoulder joint, you will see the long head of the triceps will be coming in. The only head of the tricep which originates from the scapula, otherwise remaining two heads, they originate from the humerus only. So this is the long head of triceps, long head of triceps, which is present below. And because we're talking about, we have removed the humerus, guys. Imagine the humerus head is here, anatomical neck is somewhere here, so surgical neck will be in this region only. Like imagine if my forearm here is representing the humerus, here is the head, and then we have the shaft. So surgical neck of the humerus will be somewhere here, and what you will see, winding around the surgical neck of the femur, of the humerus, we have artery and the nerve. The artery is the posterior circumflex humeral artery, and the nerve is the axillary nerve. The same two structures which we saw in the quadrangular space of the scapula. So that PCH, a posterior circumflex humeral artery, and axillary nerve will be seen in the inferior relation of the shoulder joint. So this picture is quite simple here. If you just draw it schematically, you can easily remember that what are the relations, important relations of the shoulder joint. Anterior relations, may we have subscapularis and the anterior fiber of deltoid, the main relation. Posterior, may we have posterior fiber of deltoid, the infraspinatus and teres minor. Superior relation, may we have what? Supraspinatus, we have coracoacromion arch. And I can add one more thing to this, that deep to the coracoacromion arch and the acromion process, there is a bursa present here. And that bursa is called as a subacromion bursa. That bursa here is called as subacromion bursa. We can call it subdeltoid bursa also, because deltoid muscle will also originate here and come outside. So subacromion or subdeltoid bursa, that also comes. So everything in here comes into the superior relation. And the inferior relation is clearly the long head of the triceps this time, along with the posterior circumflex humeral vessels and axillary nerve. Let me show you one picture in which we can appreciate all these relations of the shoulder joint. It's a picture from the 41st Grays only. Now first, if you can look at this image, it shows us few things here. That's a capsule you're looking at, guys, and you can see an extension. If you look at, there is one extension, you can see an aperture here. This aperture is the one which is allowing, this aperture is for subscapular bursa. That subscapular bursa, we said, will be coming out from the aperture on the anterior aspect of the capsule. I'm not able to appreciate those three bands of the glenohumeral ligament because I said you can appreciate them from the inner side. Outside it all looks smooth here. But yes, one ligament which I can see clearly coming from the base of the coracoid process and going toward the greater tubercle, and that is the coracohumeral ligament. That here is the coracohumeral ligament which can be appreciated. Don't worry about all these cut sections. These are the cut section. Like this is a cut section of the supraspinatus tendon. That's a cut section of the subscapularis tendon. So these are the muscles. Basically, it's a rotator cuff muscle you're looking at. That's a tendon of the subscapularis. This is the tendon of, no harm in writing here, that's a tendon of subscapularis. That's the subscapularis tendon. And the one that you see above here, that's a supraspinatus tendon. That is a supraspinatus tendon, and similarly we'll have some tendon at the back also. You can also see in this picture the long head of biceps brachii. You can clearly see the long head of biceps brachii coming out along with the synovial sheath. Look at that synovial sheath over there, which is covering the long head of biceps brachii. And look at this ligament, which is keeping this long head of biceps brachii in check. And that, what ligament is this? That is the transverse humeral ligament. This ligament is a transverse humeral ligament, which is holding the long head of the biceps brachii and preventing the nipping out of this tendon. Let me take you to the picture where we can again just compare the relations of the shoulder joint. Now, look at this. That's a picture I was talking about, taken from the 41st edition of Gray's only. And I just flipped the image so that it matches with what we drew. So once again, guys, this here is the glenoid cavity, right? And I hope you can appreciate clearly this long head of biceps brachii. That's the long head of biceps brachii muscle, which is emerging from the supraglenoid tubercle. Then you can see the capsule, which is present all around, and you can also see the aperture. Look at that aperture is for the subscapular bursa only. For the subscapular bursa only. And the muscle, which are the rotator cuff muscle. Now we have this huge tendon of subscapular. This whole thing is subscapularis, which I'm highlighting with the yellow here. Let me try to use a different color to show these muscles. So that is the subscapularis muscle. The one that you see above here, that is a supraspinatus. There we go. The one which I highlighted with the yellow here, that is the supraspinatus tendon. Then showing with the green here, that is infraspinatus. You can see it in two parts, but that both are the infraspinatus only. When you look at the infraspinatus muscle, that's how it originates. So it looks like as two muscle bellies are going together, they converge together, but it's one muscle only, and that is the infraspinatus itself. The muscle is the infraspinatus, and then finally this here is the teres minor. One of which is shading with this pen only, that is teres minor muscle. So that's the rotator cuff for you. The subscapular is in front, supraspinatus above, teres minor, infraspinatus and teres minor are at the back. In the lower support, I hope you can appreciate the long head of triceps here. That's the long head of triceps to be seen. That's a long head of the tricep which we see coming from the infraglenoid tubercle. Above, just above supraspinatus, look at this bursa here. That is what bursa? That is a subacromion bursa. That is a subacromion bursa. And I hope you can also appreciate this ligament which is forming the coracoacromial arch. So that is the coracoacromial ligament which is forming the coracoacromial arch. That's the acromion process where I'm pointing at right now. That's the acromion process. This is the coracoacromial ligament here, and coming to this bony thing, that is a coracoid process. So that's coracoacromial arch or the ligament here. And see, there's certain additional relation which you can remember by looking at the picture only. If I say what is the superior relation of the shoulder joint, obviously we have this bursa and this supraspinatus muscle, we have this arch. But even above that, we have deltoid muscle. The deltoid muscle is something which is forming the relation superiorly also, posteriorly also, anteriorly also. That's how the muscle is covering the entire shoulder joint. Also, if this is a coracoid process, there are two muscles which originates from the coracoid process. One is the short head of biceps, and along with the short head of biceps, it's coracobrachialis. So obviously, when these two muscles will originate from here and they go downward, they are forming the anterior relation only. Coming from the tip of the coracoid process, the muscle goes down, straight down like this in the arm. One is the short head of biceps. Long head is this one. That's a short head of the biceps coming from coracoid process, and also the coracobrachialis muscle. So these two which are shown here is the short head of biceps brachii and coracobrachialis. So that is about the relations of the shoulder joint. And finally, let's talk about the movements which are taking place in the shoulder, movements and the muscles. So I'll be going with all the main and accessory muscle together only. Now starting with the flexion first. The flexion movement of the shoulder. See, the flexion is done by the muscle whose fibers are to be running toward the humerus and slightly downward. Like, think about it. Anterior fiber of deltoid is running like this, so this will help in the flexion. Pectoralis major is having two fibers. We have a sternocostal fiber and we have a clavicular fiber, and it's the clavicular fiber which goes down. So clavicular fiber of pectoralis major will also do the flexion. Okay. Then biceps and coracobrachialis, we just saw, they are coming from the coracoid process. The short head of biceps and coracobrachialis, they are also coming from the coracoid process and straight down. So they also will help in the flexion. So when it comes to the flexion, the main muscle is the clavicular part of pectoralis major and anterior fibers of deltoid. So these are the two main muscle if you look at the flexion at the shoulder joint: clavicular part of the pectoralis major or clavicular fibers of the pectoralis major and anterior fiber of deltoid. But along with that, also the coracobrachialis and short head of biceps brachii will also help in the flexion. So we can call them, these are the primary muscles, and these are the synergist, or you can say these are the main muscles and these are the accessory muscles, whatever. But overall, all these muscles are required for the flexion. The next in the line is the extension. Now extension of the flexed arm, or simply extension here. Once again, this time it's the posterior fibers of deltoid. Same principle, it's the posterior fiber of the deltoid which will cause the extension. They are present posteriorly and running downward. And the latissimus dorsi muscle, guys. Latissimus dorsi, it's the broadest muscle at the back, and the muscle is inserted on the humerus only. So if the arm is flexed, the latissimus dorsi fibers will be oriented in this way. And when the muscle will contract, it will pull the humerus back to its neutral position. So extension is by the posterior fiber of deltoid and also by the latissimus dorsi. Now once again, these are the two main muscles which are causing the extension. Apart from that, even teres major muscle, which is again at the back, the teres major muscle. Okay. Teres major muscle is coming in front of the humerus only, but it is starting from the back. So again, if the arm is flexed, the teres major muscle and the long head of tricep, which is already there at the back, will also help in the extension. Again, these are accessory muscles, or you can say they are the synergists. Which two? The teres major, remember that it's major, not the minor, teres major, and long head of triceps. The third and the very, very important movement, that is the abduction at shoulder. Shoulder abduction, as we know, it can be divided in three parts. First 15 degree, 15 to 90 degree, and then overhead abduction, which is still 180 degree. So guys, 0 to 15 degree of abduction, we've discussed that during the brachial plexus also. 0 to 15 degree of abduction, it is done by the supraspinatus. So basically, initiation of the abduction is done by the supraspinatus. From 15 degree to the 90 degree of abduction, it is done by the middle fibers of deltoid. Middle fibers of deltoid are multipinnate. It's a multipinnate middle fibers of deltoid are responsible for the abduction. Middle fiber of deltoid. Guys, middle fiber of deltoid are also called as the acromion fiber because they come from the lateral aspect of the lateral border of the acromion process. They come from the lateral border of acromion process, so we also call them the acromion fiber or middle fiber, same thing. And then 90 to 180 degrees, or the so-called overhead abduction. The overhead abduction. This overhead abduction, it is done by the rotation of scapula. So basically we got to rotate the scapula outwards, and that will allow the more freedom for the humerus to cause abduction. So rotation of the scapula, which is done by serratus anterior, and also by the upper and lower fibers of trapezius. Upper and lower fibers of trapezius. So serratus anterior and upper and lower fiber of trapezius, they are responsible for the overhead abduction. So three part we can divide the abduction into: first 15 degree, 15 to 90 degree, and then after 19 till 180 degrees. So supraspinatus, middle fiber of deltoid, or you can say acromion fiber of deltoid, and then it is by the serratus anterior and upper and lower fiber of trapezius, which allows the scapula rotate outwards, and that will provide the more freedom to the humerus. This is called as a scapulohumeral rhythm. For every 1 degree turn of the scapula, the humerus can rotate 2 degrees more. For 1 degree of scapular movement, humerus can rotate 2 degrees more. So for 90 to 180 degrees, if I divide it that way, from 90 to 180 degrees, that means we have total 90 degrees. From here till here it is 90 degree. From here till here it is 90 degree. So in this 90 degree, the scapular movement is actually 30 and humeral movement is 60. Now it's not that the first we have a scapular movement and then we have a humeral movement. It is basically ratio. For 1 degree scapular movement, 2 degree humerus. For 1 degree scapular movement, 2 degree humerus. And combinedly it is called as a scapulohumeral rhythm. That's how the scapula and humerus, they form a rhythm, that if scapula moves 1 degree, the humerus will move 2 degrees, and we regard it as the scapulohumeral rhythm, which is required for the overhead abduction. From abduction, coming to adduction. Adduction, well, the arm is abducted already. Now we need to take the arm close to the body. Adduction. How the adduction is done? Again, the fibers which are running horizontally. See, it's very simple. It's very easy to remember that which muscle causes adduction. Whether muscle is present in front or it is present behind, doesn't matter. But if a muscle is present anteriorly or posteriorly and running horizontally toward the humerus, not superiorly, I'm saying it is anteriorly or posteriorly and running horizontally toward the humerus, that will obviously pull the humerus inside. Like this time, the sternocostal fibers of pectoralis major. Clavicular fibers were causing flexion. I'm talking about sternocostal fibers of pectoralis major will cause adduction. 1. Latissimus dorsi, it was coming from the back, but again the muscle is more transversely oriented. So again it will help in the adduction, pulling the humerus inside. If you look at the back, the muscles like teres major muscle. Teres major muscle is coming from the lateral border of scapula and again coming to the shaft of the humerus, to the medial lip of bicipital groove. Again the muscle is horizontally oriented, will help in the adduction. So these are main muscle which will help in the adduction. So the muscle goes like, we have the sternocostal fibers of pectoralis major. Sternocostal fiber of pectoralis major. Latissimus dorsi. And once again, apart from these two muscles, some muscle which are also there, like they are not the again main muscle, they help in the adduction, and that is like subscapularis. Guys, even subscapularis is oriented transversely. Teres major muscle is also oriented transversely, and they will also help in the adduction. Main muscle is the pectoralis major, sternocostal fiber, and latissimus dorsi, also helped by the subscapularis and teres major. After that, what is the other movement at the shoulder we have? We have internal rotation and external rotation. Internal and external. Now, when I say internal rotation, obviously, again, the muscle running horizontally toward the humerus, toward the shaft of the humerus, or anything toward the humerus only, but anteriorly. If a muscle is present anteriorly and coming to the anterior aspect of the humerus horizontally, that will cause the medial rotation. So there are some muscles which are those starting from the posterior side, like latissimus dorsi is coming from posterior side, teres major is coming from posterior side, but ultimately they come in front of the humerus. These muscles are coming in front of the humerus when they attach to the bicipital groove. So any muscle which is supposed to come on the shaft of the humerus transversely anteriorly to the humerus, they will cause the internal or medial rotation, like pectoralis major, again teres major, again latissimus dorsi, all these muscles, because they're all coming in front. None of them is going behind. So internal rotation, or so-called the medial rotation. Internal rotation or medial rotation is by the subscapularis, pectoralis major, latissimus dorsi, teres major, and also by the anterior fibers of deltoid. Also by the anterior fiber of deltoid, the muscle which is present here, the contraction of these that muscle is not only causing the flexion, is also causing the internal rotation. Similarly, external rotation or lateral rotation, guys. External or the lateral rotation. Well, in external rotation, the muscle fiber need to be present on the posterior side. So once again, it has to be the posterior fibers of deltoid, which helps in extension also. The posterior fiber of deltoid. Infraspinatus, and this time it's the teres minor muscle. If you look at the infraspinatus and teres minor, again these muscles are horizontally placed. Both these muscles are the muscles of rotator cuff. That's why it's a rotator cuff. The muscles are present at the back and they help in the external rotation of the humerus here. Subscapularis was in front. So subscapularis is causing what? The subscapularis muscle is there. That is subscapularis. So subscapularis is for what? Internal rotation. Infraspinatus and teres minor are behind. They are for external rotation. And supraspinatus is above. That is causing the abduction. And that's about the rotator cuff we said. I repeat again. Supraspinatus is at the top. That's why it helps in the abduction. Subscapularis is in the front. So it helps in the internal rotation and adduction also, I can say. And the muscle which is at the back in the rotator cuff, that is teres minor and infraspinatus, they both help in the external rotation. So that's about the muscles and the movement at the shoulder joint. Muscles and the movement. Nerve supply to the shoulder joint, guys. The nerve supply to the shoulder joint, it comes from the axillary nerve and also by the musculocutaneous nerve. The axillary and the musculocutaneous nerve, they both supply the shoulder joint. It's not musculocutaneous, I'm sorry. It is axillary nerve and the subscapular nerve. The nerve which supplies the subscapularis. Let me write that for you. Nerve supply to the shoulder joint, it comes from axillary. So axillary nerve supplies the deltoid and teres minor and the shoulder joint also. And also by the subscapular nerve. If you look at both these nerves are coming from the posterior cord of brachial plexus. Axillary nerve as well as the subscapular nerve, upper subscapular, lower subscapular, they are coming from the posterior cord of brachial plexus. So in other words, I can say that it's the posterior cord of brachial plexus which supplies the shoulder joint. And one thing to be understood by looking at this muscle arrangement and the support of the shoulder joint is that shoulder joint is supported from anteriorly, superiorly and posteriorly. So we have rotator cuff present all around. And that's why anatomically we say that dislocation takes place in the inferior direction. Well, once the dislocation of the humerus takes place in the inferior direction, the humerus is not going to stay downward only or below only. The muscles which are the strongest group of muscle include the flexors and the adductors. The flexors of the shoulder and the adductors are the strongest group of muscle. And that's why once the humerus comes down, all those muscles which are responsible for the flexion of the arm and the adduction of the arm, they will come into the picture. And that's why the humerus will, once it goes downward, it also comes in front and it comes close to the body also. So like it's flexed and adducted. And that's why the head of the humerus is subcoracoid. It comes just below the coracoid process. We call it subcoracoid humerus, and that is basically the anterior dislocation only. When I say anterior dislocation, the anterior dislocation is the head goes down, and then because of the strong flexors and adductors, it comes like in front and it goes close to the body, like in this position. That's why the shoulder, dislocated shoulder, anterior dislocation of shoulder, which is the most common, the humerus is seen, the head of the humerus is seen subcoracoid in position. Subcoracoid in position. So that's a little bit about the shoulder joint, about how the joint is formed, about its articular congruency, the support, the additional support, the relations of the joint, muscles in the movement, nerve supply. and about that when the shoulder joint dislocates, what will be the final position of the head of the humerus.